We'll start the recording and we'll go over the neoplastic thyroid today, which is the thyroid cancers and thyroid tumors. So let's dive in. It looks like he didn't update the cytology notes yet, or the thyroid notes yet. So his last update was 2020. So there's no new version for this notes. Hopefully, maybe there's not much details added, or it will be modified soon. So keep in touch, like stay in touch on the website. He always like upload the new versions of the notes. The thing is, I think he always posts the updates on his Twitter or his X account. But he doesn't mention on the website whether a new version of Thyroid Notes was uploaded or a new version of this is one of the things, or one of the feedbacks that I need to give to him. He's very responsive to feedbacks, by the way. So I'm planning to tell him, like, maybe on the website, just have an area in which you say that you uploaded a new version of this notes or that note, so that everyone like stay on track. But let's get started on the thyroid tumors. Well, the thyroid tumors, you have of course the three key entities, which are the papillary thyroid cancer, or the papillary thyroid carcinoma, and the follicular carcinoma, in which we struggle to differentiate between follicular adenoma and carcinoma. So we usually take them together, bunch them together. And then you have the medullary thyroid cancer. And then finally, you have the undifferentiated thyroid cancers and the anaplastic type, or the anaplastic carcinoma. These are the key entities for the thyroid tumors. There are some other rare tumors like salivary gland-like tumors like mucoepidermoid carcinoma of the thyroid. This kind of rare stuff, it would never be asking questions. However, the boardable entities are these 4 or 5 main entities of thyroid tumors that you need to digest like head to tail. So let's start with papillary thyroid carcinoma, the PTC. PTC, the 3-star diagnosis. You will get a lot of fine needle questions, cytology questions, histopathology questions, everything. And why it's very common in questions? Because it's the most common form of thyroid cancer. So it makes sense. It's highly related to ionizing radiation, and it's usually presents as an euthyroid painless mass, usually solitary, in a woman. So it's more common in females. And it's usually painless thyroid mass, solitary. The key histopathology feature is being able to identify the nuclear features, or the characteristic nuclear features for PTC, which we previewed yesterday. If you remember, we had an incident that I told you the mnemonic for the nuclear features of the papillary thyroid cancer, which is the vowels. What are the vowel letters? They are the E, A, I, O, U. So E stands for enlargement. You have nuclear enlargement. And of course, if you apply these criteria on the image, you'll be able to see it. So the nuclei here are very enlarged. That's enlarged. And A stands for asymmetry. Asymmetry means that you are having some kind of irregular nuclear contours. The nuclei are asymmetric. They are not very circular. They are very irregular. So as you see, like for example, here, see this nucleus, and this nucleus. It's not regular, not very rounded, not fairly rounded, not fairly circular. And sometimes they are, see, they are punched from one side. Here also, see, it's punched from one side. So that's what I mean by irregular nuclear contour. That's asymmetry. So I stands for the inclusions, which are actually pseudo inclusions. Here it is. That's how the inclusion look like. And these inclusions are actually due to cytoplasmic projections or finger-like papillary cytoplasmic projections coming out from the nucleus. So when you take a section, this projection appear as a hollow or appear as a circle. That's how it is. It's not an inclusion, it's a pseudo inclusion, because it's not true inclusion. There is nothing there inside the nucleus. It's just a projection which you took a cross section, so it appeared as a circle inside the circle. So that's the pseudo inclusion. It's due to papillary cytoplasmic projections coming from the nuclei. O stands for overlapping. The nuclei are always like near each other, touching each other, sometimes on top of each other, like these three nuclei. Can you see that? These three nuclei are very overlapping on each other, and like these three nuclei here. So that's the overlapping O, and then finally the U is the grooves, which is, I always say, U-shape. U-shape, the U has a groove. It's a groove. Grooved means like a U. Grooving or nuclear grooving. The nuclear grooving make the nucleus sometimes look like a coffee bean, like this one. See that groove? Here's the groove in the nucleus, which make it look like the coffee bean. So coffee bean nuclei or grooved nuclei. So you should not have all the nuclear features, but you usually have at least 4 of them. So E, A, I, O, U, aside from the chromatin clearing, like the clearing of the chromatin, the chromatin might look very clear to the point that the nucleus look as if it's empty from inside. And sometimes they call this orphan Annie nuclei. Yes, it's orphan Annie nuclei. Like this orphan Annie, I think it's a cartoon character or a cartoon character, because but we as Egyptians, I never know about orphan Annie. I just we just like we are addicted to other kinds of cartoons when we were young. We never used to watch this orphan Annie, but I just knew about it when I studied the papillary thyroid cancer, honestly, and that's why I googled it. I didn't know what's orphan Annie, and then it turned out that it's, I think, a cartoon character or something like this. So it's a scary looking face. Oh, okay. So I don't know, honestly, but it's a EAIOU. That's the nuclear features of the papillary thyroid cancer. However, you might be shocked about how many entities exist under the PTC. Like a lot of patterns, conventional, papillary, encapsulated, follicular, tall cell, columnar, diffuse sclerosing, cribriform modular, and it doesn't stop. It never stops. It just never stops. See, there is other variants like hobnail, solid, trabecular, oncocytic, spindle cell, clear cell, Hurthle-like. You'll be shocked about how many variants exist under the PTC as an entity. However, the only variants that I will highlight for you is the ones that were asked in questions, which include, of course, the conventional type, the classic type, which look papillary. You see papillae, see? So I see papillae. What's a papilla? It's like a lining, epithelial lining, and a fibrovascular core. So here is a fibrovascular core here, and here is the epithelial lining all around, and the epithelial lining is showing the classic nuclear features of papillary thyroid cancer. That's it. Boom. That's conventional or classic PTC type. You sometimes face this type as a diagnosis question. Sometimes you might see some occasional squamous metaplasia. It's okay, but as long as you see the papillary architecture here, And you see the lining cells which have papillary nuclear features. You might see some Samuma bodies, of course, because this is papillary thyroid cancer. So it has Samuma bodies. We know that there are 4 classic tumors which have Samuma bodies, which are the 2 M's and the 2 papillaries. The 2 M's are the mesothelioma and meningioma, and the 2 papillaries are the papillary thyroid cancer and sometimes the papillary ovarian cancer, which is papillary like the serous, the serous, papillary serous carcinoma of the ovary. Sometimes it has some Samuma bodies. So here you might see also some Samuma bodies, papillary architecture, and the nuclear features of papillary thyroid cancer. So this is the first one that I need you to know about. The second one is just for your knowledge. It's for your practice. It's the follicular variant. It actually has follicles. There's no papillae. No papillae. I see follicles. So you see the classic thyroid follicles with the colloid or the thyroglobulin in the middle, but the lining cells of the follicles show papillary nuclear features. This means that it could be a follicular variant of papillary thyroid cancer. And this is when the experience come in play, because now you don't know whether this is follicular carcinoma or papillary thyroid cancer follicular variant. So there come the experience and of course the molecular as well, as I will talk later. So follicular variant, you might see follicles, and you might see, and these 2 things are common also in the boards, the tall cell variant and columnar cell variant. I didn't see columnar cell variant in any question, but I saw tall cell. Why they ask about tall cell variant? Because when you see these tall cells mean the cells are 2 to 3x tall more than the width. The length is 2 to 3 times more than the width. But the nuclei is the key here. The key to differentiate between tall cell variant and columnar cell variant are 2 things. The site or the location of the nucleus. In tall cell variant, the nucleus is usually in the middle of the tall cell. So it's in the middle, more towards the apex though. But in the columnar cell variant, the nuclei are usually basal. It's colon-like, like adenocarcinoma-like or colon adenocarcinoma-like. They have these columnar cells which are thin and tall, and the nucleus is in the base, like this. That's columnar cell variant. But this is a tall cell variant. You got it? So that's the tall cell variant. Talls, if you are in between tall and columnar, believe me, it will be tall cell. Why they ask about tall cell that much? Because it has an aggressive behavior. It has a worse prognosis, so it's a prognostic indicator. So if you see this tall cell variant of papillary thyroid cancer with papillary nuclear features, and you see the tall cells, you say, this means a bad news for the patient, because it's associated with high incidence of metastasis and high incidence of aggressive behavior. Diffuse sclerosing variant, it was asked in only 1 QBank, which is Path Primer. And he asked it as a diagnosis, as a picture. And that was a tough question. That's why I got a picture for that, because in Kurt notes, there's no picture for the sclerosing, for the diffuse sclerosing variant. Here we go. So we have, Noor said we had 2 cases of diffuse sclerosing. Looks like the head and neck is a heavy service in your program. If you had like 2 cases of diffuse sclerosing, so this means that this is heavy service. So it's like the name actually implies everything. The name says everything. So I'm seeing papillary thyroid cancer. So it's nuclear features of papillary. So nuclear features of papillary, which is EAIOU. Well, I see that here. If you look at these nuclei and apply the criteria, you will see that it applies. Well, these are papillary nuclear features. But you see a lot of sclerosis. See in low power. See all this. Let me change the color so that you see it. See, all this, the whole of this thing is sclerosis and fibrosis. All these dense bands of sclerosis, fibrosis running through the tumor. It's as if it's like a map. And you have a lot of lymphocytic infiltrate for some reason, and a lot of calcifications and samuma bodies. That's the diffuse sclerosing variant. So there is a lot of sclerosis, diffuse sclerosis, and it's a very rare entity. And that's why I'm telling Noor that if you got 2 cases of diffuse sclerosing variant, this means that you are having a heavy service, because that's a rare entity. With sclerosis and solid nests of tumor cells, there is also some kind of background lymphocytic inflammation and a lot of samuma bodies. This one also is a board favorite and RISE favorite. I think they asked it in the last RISE exam. Cribriform morular variant. The cribriform morular variant. What's specific about it? It just have some solid nests. See, a lot of solid nests. That's why they call it morular, because you have moruli or masses of cells with papillary nuclear features, and there is cribriforming. There's holes in these like morules. So morules with holes. That's the cribriform morular variant. They never ask you as a spot diagnosis for this entity, but they always ask about the associated mutation. It's associated with FAP mutation, which is a mutation in the beta-catenin pathway, which is actually the FAP gene, the same gene involved in what? Anybody know? It's the exact same gene involved in what?
Adenomatous polyposis coli.
Yeah, colonic polyps and colonic adenomatous polyposis or familial adenomatous polyposis. That's why I say the cribriform morular or the cribriform variant is associated with the same gene which lead to colon polyps, like C with a C, cribriform colon, FAP, familial adenomatous polyposis, which is, or familial adenomatous polyposis coli, familial polyposis coli. Well, IHC wise, all the thyroid lesions are TTF1 positive, PAX8 positive, thyroglobulin positive. Even the normal thyroid tissue, I believe. And that's why histology and HLE is still a key in diagnosing thyroid tumor. However, it was highlighted in one of the Q banks that's why I added this information. CK19 is diffuse and strongly positive in papillary thyroid cancer. Of course, the classic mutation and the most common mutation in papillary with a P for pen is BRAF with a B for baby. So it's a P with a B, papillary thyroid cancer with BRAF, most commonly the V600E mutation, which is the exact same mutation existing in melanoma and what else? Well, hairy cell leukemia, good job. Hairy cell leukemia, I agree. And something like some kind of a polyp. Anybody know?
It has also something with the renal carcinoma, I guess.
One of the renal cell carcinomas is not a common question, but we will anyway. We will review that. We will preview that. But just BRAF, the most common is melanoma. Everyone remember this melanoma, BRAF V600E, and also hairy cell leukemia. And here the papillary thyroid carcinoma. Also, you need to remember BRAF. So papillary thyroid carcinoma in brief. Papillary thyroid carcinoma, you need to know the papillary nuclear features, EAIOU, okay? You need to know that this is the most common thyroid cancer, and you need to remember some variants, the classic variant for the sake of histological diagnosis, and the tall cell variant tall, width, 2 to 3 times tall than width, tall cell variant because it's aggressive, poor prognosis, diffuse sclerosing variant only asking in only one Q bank, cribriform, you need to remember this for the FAP mutation association, and you need also to memorize the associated molecular alteration, which is the BRAF V600E. It's also associated with RET, RAS, TERT promoter, and a lot of stuff. But BRAF, for some reason, is always the most common, and it's always even the most common in the Q banks and in the questions. Okay, most common way of metastasis for the papillary is lymph nodes. Remember this. Papillary thyroid cancer most commonly metastasized by lymphatics. Follicular carcinoma most commonly metastasized by blood. Anaplastic carcinoma most commonly metastasized locally, or it has local spread. And finally, medullary thyroid cancer, it might metastasize by lymphatics and veins. It's also blood, so it makes sense, like hematogenous and lymphatics, so both. So again, papillary, lymphatics. Follicular, hematogenous. Anaplastic, local. Medullary, both lymphatics and hematogenous. Lymph nodes and local and hematogenous. Lymph nodes and hematogenous. So someone is saying, Hike is asking, is tall cell associated with P53 mutation? Possibly. It makes sense that it's aggressive, but someone can check real quick and let us know. Someone can check real quick and confirm. Can you check online? But it makes sense. It has an aggressive behavior, so it might be associated with P53, who knows?
I checked and yes, it overexpressed P53.
Yeah, so okay, so makes sense. It's very aggressive. So Noor is having a question. Follicular variant again. Follicular variant is just it looks like follicular carcinoma, Noor. So we will talk about follicular carcinoma right now. So it looks like follicular carcinoma, but it shows the classic papillary nuclear features. So this means that if you see follicles, this doesn't necessarily means that you are dealing with a follicular carcinoma. You need to go high power and look carefully at the nuclei and make sure that there is no papillary nuclear features. Otherwise, it's going to be papillary thyroid cancer with the follicular or follicular variant or with follicular features. So that's the follicular variant. So see, it's saying that follicular variant exclusively or almost exclusively follicular. It can be infiltrative or even encapsulated with invasion. So that means it might look exactly like follicular, but it shows the papillary nuclear features. You know that? So that's what it means. Hobnail, I don't care. I mean, I don't care about hobnailing, but hobnailing, if you want to know what this means, pathologically, hobnailing means that the cells are like this. That's what hobnailing means. That's what hobnails mean. So, but I never saw it, honestly, neither in questions nor in practice until now. I don't know. All right. So follicular adenoma, here is the follicular adenoma / carcinoma. So now we are struggling when we are seeing a follicular lesion. Now we need to know how we can differentiate whether this is follicular adenoma or follicular carcinoma. But remember from our previous session, which was yesterday, we talked about how to differentiate follicular adenoma from an adenomatoid nodule or colloid nodule. So you need also to know this with multinodular goiter versus follicular adenoma. And we had a table yesterday and we said the encapsulation and whether it's single or multiple, and we talked about it. Now we are in the follicular adenoma side. Is it follicular adenoma or follicular carcinoma? That's what we are dealing with today. So follicular adenoma is actually benign neoplasm, and it's always encapsulated, entirely surrounded by a capsule like this one. Here is the capsule in high power. And what you see actually is crowding of follicular cells. Like, compare the normal thyroid tissue that you see here and the adenoma tissue that you see here. You see that if you go high power on the adenoma area, you will see that there is crowding of the follicular cells. The follicular cells are very crowded to the point that they are making some kind of microfollicles. Microfollicles with a little bit of colloid inside, but they are very crowded to the point that there is no space for the colloid to occupy. Like, look at this low power picture. You will see that the little bit of colloid here, a little bit of colloid there, a little bit of colloid here. That's why the meaning of microfollicles. So it's very crowded area of follicular epithelium or follicular cells, and the cells doesn't show any papillary nuclear features, and they does not show malignant nuclear features even. But this is not the key. The key is not whether the cells are showing malignant features or not. The key is what? The key is
the key for
saying whether it's follicular adenoma or follicular carcinoma. It's not depending on how malignant the cells do.
yeah,
depends
capsule
on
LVI.
The capsular invasion / vascular invasion.
Yeah.
That are the two things. So capsular invasion / vascular invasion. These are the two things. See, absent. See, he's making it all caps. So all caps means this is the key thing. This is the thing that we rely on, which is capsular invasion / vascular invasion, and whether there is any PTC-like nuclei or not. So absent papillary nuclear features and absent capsular invasion and absent vascular invasion with proliferation of follicular cells to the point that you're seeing some kind of microfollicles with a little bit of colloid in between. And you can see a clear, distinct boundary between the adenoma tissue and the normal thyroid tissue on the other side, with a capsule in between. So it's well circumscribed, surrounded by a fibrous capsule. So you have to submit, when you have a well circumscribed thyroid nodule, that you're suspecting that this is a follicular adenoma / carcinoma, you need to submit sections from all the capsule. The whole capsule need to be submitted all around the mass, so that you look at the whole capsule and look for any capsular invasion or vascular invasion in the capsule wall or in the mass, in the wall of the mass. So absent capsular vascular invasion, absent papillary nuclear features, cells are kind of cuboidal with rounded, basally located nuclei. See, there is smooth nuclear contours, uniform chromatin. It doesn't tell whether it's malignant or not. Two things that you need to memorize here: the molecular and the syndromic association. Follicular adenoma, on the other side, if you remember, okay. So follicular adenoma on the other side is associated with RAS mutation, whereas you remember PTC was associated with BRAF mutation. So yeah, mad cow. Oh yeah, this is the Coden, right? I mean the Coden syndrome. The Coden syndrome is for the cow, right? That's what you mean, Lord. Yeah. Okay. So it's associated with RAS mutation, and it's associated with two syndrome with the C letter, C and C, which are Coden syndrome and Carney complex. Coden syndrome and Carney complex are both, allergy. So Coden syndrome and Carney complex are associated with follicular adenoma / carcinoma as well. and the RAS mutation aside from BRF, which was associated with papillary. See, that's how capsular invasion should look like. So you need to know how to differentiate between true capsular invasion and pseudo-capsular invasion. And you need also to be able to differentiate between the true vascular invasion and the pseudo-vascular invasion. So let's start with the true capsular invasion versus pseudo-capsular invasion first. So see, it requires, for diagnosis of follicular carcinoma, it's the same exact features of follicular adenoma. And the same thing, absent papillary nuclear features. However, there is either capsular or vascular invasion of both, capsular and vascular. And it commonly spread hematogenously, the follicular carcinoma. So see, to say that this is capsular invasion, you need to have a penetration of the entire capsule, like this. The cells are forming a true bulge in the capsule, penetrating most or even the whole capsule to the outside. And they call this the mushrooming. It's called the mushrooming because there's look like a mushroom. So they call it mushrooming. So mushroom appearance. So look at this picture. I love this picture. It's very good. So see, here is the fibrous capsule highlighted by green. So here is the outer boundary of the capsule and here is the inner boundary of the capsule. So look at this. So you have to make sure that you know the outer boundary or observe the outer boundary of the capsule under the microscope. If you see that there is some kind of tumor penetration, but it's not reaching the outer boundary of the capsule yet, so this is not true capsular invasion. So it needs to be like this. Completely penetrated the capsule, or like this. That's a yes, and that's a yes. See, sometimes it's penetrating the capsule, but there is some kind of reactive fibrosis surrounding the bulging lesion outside the capsule. This reactive fibrosis is not a capsule, and this is counted as a yes. So sometimes this is also a pitfall in which you say, oh, this is not penetrating the capsule because see, I still see fibrous tissue here. But no, this is not the fibrous tissue of the capsule. That's reactive fibrosis or reactive sclerosis that happened due to complete capsular penetration into the surrounding stroma. So you need to look for that and gain experience in this. So look at the outer boundary of the capsule or the outer line of the capsule. If the tumor extends beyond this line or this imaginary line that you form by your eye under the microscope, so this means that you're dealing with a true capsular invasion. And see this, like a tumor might send a satellite outside the capsule. You see a satellite of the tumor outside the capsule. That's a yes, of course. However, see, like you sometimes see satellites of the tumor, but it's still in the capsular wall. That's not yet. No, it's a no. So make sure this one also, it's a no. This one, it's a no. This, it's a no, because it didn't get to the outer boundary. So that's how you gain experience in getting to know the true versus pseudo capsular invasion, because this completely changed the management and completely changed the diagnosis from follicular adenoma to follicular carcinoma. And for you to say that there is vascular invasion, you need to have two criteria, which are tumor cells inside the vessel is not enough. Tumor cells inside the vessel is not enough because it could be a tangentially cut. Like it could be some kind of cut which had like tumor cells in one level and the vessel wall in the other level, and both of them appeared in the same level, one inside the other. It tells you that the tumor cells are inside the vessel, but they are actually not there. They are not inside the vessel. So you need to see the tumor cells adherent to the vessel wall. That's a very important criteria. So see, the tumor cells should be adherent to the vessel wall. And preferably, they should be making a tumor thrombosis or cancer thrombosis due to cancer spread inside the vessels. So the cancer cells are producing some kind of reactive thrombosis there. So tumor cells adherent to the vessel wall with vessel fibro or with vessel thrombosis or intravascular thrombosis. So see, for vascular invasion, look at this. For vascular invasion, tumor cells should be adherent to the vessel wall, either with covering endothelium or in a thrombus with fibrin. Preferably, there should be a fibrin inside. Yes, Noor is saying adherent to the endothelium. So look at this. See this? Like this one, it's a no, because I see tumor in a separate island than the vessel wall. They are not associated with each other. Here, it's a no, because here just the tumor is just reaching the vessel, but it's not intravascular, it's not inside the vessel. Here also it's a no, although you see multiple tumor cells or multiple masses of tumor cells inside the vessel, they are not adherent to the vessel wall. See, like this one, that's an absolute yes, because it is a tumor adherent to the vessel wall with an associated thrombus. Here also, it's an absolute yes, because I see the tumor attached to the vessel wall and also I see associated thrombosis. That's how you can call it a true vascular invasion, rather than it's just a pseudo vascular invasion or pseudo invasion. So for the capsule, the invasion must occur in the capsule or beyond. And for the tumor, for the vascular invasion, it should be a true vascular invasion. And that's why we subdivide the follicular carcinoma into 3 groups. Not important for the boards, but it's important for practice. Minimally invasive, angio-invasive, and widely invasive. Minimally invasive is when you invade the capsule only. Angio-invasive is when you invade the blood vessels only. And widely invasive is when you invade both. So if you invade only the capsule, that's minimally invasive. If you invade the blood vessels, that's angio-invasive. And if you invade both, that's widely invasive. Same thing, follicular adenoma, follicular carcinoma, both are RAS positive, RAS point mutation. And both of them are associated with Codin syndrome. The Codin syndrome, by the way, is due to P10 mutation. But we will talk about Codin syndrome in details later. It's also showing the same pattern of IHC, which is TTF1 positive, PAX8 positive, thyroglobulin positive. It doesn't show CK19 positivity like PTC though. So you remember in PTC, there was one QBank which mentions CK19 diffusely and strongly positive. CK19 could be a good stain to differentiate follicular from papillary. So Alia is asking, should I report the pseudo invasion? It's a no. You know, Alia, there is this pseudo invasion creates sometimes a lot of trouble in the IDC, the intradepartmental consultation. So sometimes there is like something like this. Look at this. See this D? D is saying it's controversial. WHO says yes. CAP would say no. So it's like, and they will start fighting. Like here, you have the tumor, which is nearly adherent to the vessel wall. However, there is no thrombosis. There is no intravascular thrombosis. Then they will start like fighting. Well, this is true invasion. Some others say, no, this is tangential cut. This is a pseudo invasion. This is not true invasion. So it's like a little bit controversial. Uh-oh. Let me, can you just give me 1 minute to check on this accident? So we had an accident outside. Can you give me like 1 minute, check on this accident? Okay, so everything is fine. All right. So, all right. So we're good with the follicular and papillary, right? So thumbs up. Everything is good. Follicular, papillary, BRAF, papillary, RAS, follicular, follicular adenoma versus carcinoma, capsular invasion, vascular invasion, papillary thyroid cancer, the variants, tall cell variant, aggressive. Okay. It's a lot of things to memorize, I know. Hurthle cell tumor. Hurthle cell tumor, you would rarely get a Hurthle cell tumor in the boards. However, you might get a question about Hurthle metaplasia or Hurthle cell metaplasia, which was associated with chronic lymphocytic thyroiditis. If you remember, we had this in the yesterday session. Same thing. So Hurthle cell tumor is actually a well circumscribed neoplasm which consists entirely of oncocytic cells or Hurthle cells. What's oncocytic cell or Hurthle cell? You told me already yesterday. It's a huge cell with huge amount of cytoplasm. The cytoplasm should be pink granular or eosinophilic granular cytoplasm. And the nuclei are very, very rounded with prominent nucleoli. See, rounded nucleus, prominent nucleolus, huge cell. Maybe it's this one. So huge cell with fair or fairly good amount of eosinophilic granular cytoplasm. That's how Hurthle cell look like. Hurthle cell metaplasia is associated with chronic lymphocytic thyroiditis. Sometimes this metaplasia form a mass and they call it Hurthle cell adenoma. Sometimes the Hurthle cells start to look weird, they start to look malignant, and they start showing some signs of invasion like vascular invasion, capsular invasion. That's called Hurthle cell carcinoma. So we have Hurthle cell adenoma, Hurthle cell carcinoma. The way to differentiate them from each other is also capsular invasion and or vascular invasion. So is it possible to differentiate Hurthle cell adenoma versus carcinoma and follicular adenoma versus carcinoma on cytology or FNA? Yes or no? Is it possible? It's a
No.
no. Good job. So it's a no. We cannot because we don't have the capsule on fine needle aspiration. The fine needle aspiration, you get some cells. So you can assess the cells and tell me whether this is Hurthle cell or whether this is follicular cell or papillary carcinoma cell. But you cannot really tell whether there is any capsular invasion or vascular invasion. So if the diagnosis rely on capsular/vascular invasion, you can't render this diagnosis on cytology or FNA. So it's see, he's saying that you use the term Hurthle adenoma or Hurthle carcinoma if the majority or like 75% of the cells in the cancer is Hurthle cell or in the tumor is Hurthle cell. Because otherwise you write down maybe follicular adenoma with Hurthle cell features, papillary thyroid carcinoma with Hurthle cell features, because you might see some Hurthle cell metaplasia aside from seeing some papillary thyroid cancer features or follicular adenoma/carcinoma with Hurthle cell metaplasia. So you would say follicular adenoma or follicular carcinoma with Hurthle cell features, papillary thyroid cancer with Hurthle cell feature. To say it's a Hurthle cell lesion or Hurthle cell adenoma/carcinoma, you need to have more than 75% of the tumor cells having Hurthle cell features. Okay. Okay. Anybody remember from yesterday why Hurthle cell has a granular cytoplasm, granular eosinophilic cytoplasm? We need to repeat this so that we memorize. It's a lot of
Mitochondria?
yes, a lot of mitochondria or a lot of mitochondria. That's why it's eosinophilic granular. Yeah, good job. Now we're going for the entities for your practice, not for the boards. Some entities to take a break from the boards, but they are fairly common in practice, which is follicular tumor of uncertain malignant potential, well-differentiated tumor of uncertain malignant potential. And the one that I don't remember who told me about it yesterday, it's the NIFTP or NIFTP. NIFTP, the NUR. Okay, that's NIFTP is the non-invasive follicular thyroid neoplasm with papillary-like nuclear features. These entities you would never encounter in the boards, because in boards, they don't ask about the gray zones. They just ask about the frank entities, the standalone entity, like a papillary thyroid cancer, follicular thyroid cancer, the associated molecular mutation in papillary, the follicular, tall cell, cribriform modular association, these kind of things. But they don't ask about this gray zone thing that needs examination of the whole slide, and it take you some time to screen the whole case so that you reach a diagnosis. No. This you never encounter in the boards. So let's have like an ABC for these entities for the sake of our practice and for the sake of our rotations. If you're rotating in head and neck, and you want to gain some exposure or want to gain some experience. So when do you call follicular tumor of uncertain malignant potential? Simply follicular adenoma plus equivocal vascular or capsular invasion. This means that the attendings disagree on whether this is vascular, true vascular invasion or pseudovascular invasion, or true capsular invasion or pseudocapsular invasion. So in case there is disagreement in IDC, sometimes they sign the case out as follicular tumor of uncertain malignant potential. So we're not sure whether this is a follicular adenoma or carcinoma. This makes the surgeon really mad. But what should we do? There is disagreement. There's no sure evidence of follicular carcinoma. So we don't want to call it follicular carcinoma. So when do you call well-differentiated tumor of uncertain malignant potential? When there is disagreement, or when there is a very few papillary thyroid nuclear feature or papillary nuclear features in a follicular neoplasm. So you have a follicular neoplasm, okay, encapsulated, well circumscribed, follicular pattern tumor, and with some kind of partially developed PTC type nuclear changes, and there is also questionable capsular or vascular invasion. So is there capsular vascular invasion? We're not sure. Is this papillary nuclear features? We're not sure. Like there is only maybe one out of the 5 or 6. Well, so I cannot say for sure that this is follicular, and I can't say for sure whether there is capsular or vascular invasion. So they sign it out as well-differentiated tumor. Well-differentiated tumor means I'm not sure whether it's papillary or follicular. They didn't say follicular tumor like here. So here, I'm not sure whether it's follicular or papillary, and I'm not sure whether it's invading the capsule or the blood vessels or not. So that's why we call it uncertain malignant potential. So uncertain malignant potential is a sign out statement for unsure or not unsure whether there is vascular or capsular invasion. This is uncertain malignant potential. Follicular versus well-differentiated is follicular is when you see follicular pattern. There's absent papillary nuclear feature, then that's follicular cancer for sure. But well-differentiated is when you are even not sure whether this is follicular or papillary. That's very tough, especially with molecular. And these are, I think, the cases which they send for molecular and see which pattern or which molecular mutation is there, like whether it's BRAF, so it's more towards papillary, or is it like RAS or RAS, so it's more towards the follicular, you know? Noor is saying MSK. MSK, yeah, I agree. MSK. MSK is, you know, the consultation, right? MSK consultation. You send for consultation, right? That's what you mean. Yes. Okay. Yeah. So non-invasive follicular thyroid neoplasm with papillary-like nuclear feature. What the heck is this? NIFTP. So just letting you know, these are the diagnostic requirements for this kind of tumor. So, well, I will tell you what it is exactly. That's encapsulated. It's like follicular. That's why they call it follicular thyroid neoplasm, okay? And it has follicular pattern of growth. Okay, so I see follicles. So that's like follicular. However, there are nuclear features of papillary. Oh, okay, with the nuclear score 2 or 3. The nuclear score actually is based on the EAIOU. How many out of the 6 you got it. And it's usually like 3 or 4 out of 6. So there is papillary nuclear feature. Well, that make it like papillary. However, no means no lymphovascular or capsular invasion, no tumor necrosis, no significant mitotic activity. Well, this means that when we reach this point, we are in between 2 diagnoses, which are follicular carcinoma, follicular adenoma, because there is no invasion of the capsule and the blood vessels, or papillary thyroid cancer with follicular features, follicular variant of papillary thyroid cancer, right? So they go ahead and send it for molecular, but the molecular come back RAS mutation and no BRAF. BRAF is notably absent. So RAS make it more towards which entity? Let me ask you this question.
Follicular.
Yeah, follicular. So it's follicular by molecular, but it's papillary by histology. And if it's follicular, there is no capsular invasion, so it would be follicular adenoma. So in this case, it has the features of follicular adenoma, and it has also the features of papillary thyroid carcinoma, but molecularly, it's more of a follicular flavor. So they call it like a non-invasive follicular thyroid neoplasm with papillary-like nuclear features. With papillary-like nuclear features means that we are seeing papillary nuclear features, but this is actually a non-invasive follicular thyroid neoplasm because molecular confirmed the diagnosis that that's follicular because of having RAS mutation and no BRAF mutation. And actually it is highly likely that this is a follicular neoplasm, not a papillary, because it shows a very, very low risk of progressive disease, low recurrence, no metastasis, nothing. It's very, very excellent prognosis. So it looks like it's a follicular adenoma. It's having some kind of pre-malignant features maybe, or it's almost turning to a malignancy. You never know. So you got it. That's the NIFTP and the follicular neoplasm of uncertain malignant potential and well-differentiated tumor of uncertain malignant potential. That's why I always say, don't bother on confusing yourself with these entities before the boards. That's my recommendation. Otherwise, if you keep confusing yourself with this NIFTP, follicular neoplasm of uncertain malignant potential, well differentiated with uncertain, you start forgetting the follicular carcinoma, follicular adenoma, and papillary thyroid cancer, anaplastic, and medullary. And these are the most important ones for your boards, not these ones. Maybe if you end up practicing head and neck or practicing general pathology, you might have to preview these every now and then in your sign-outs. Until you gain experience and be able to differentiate them from each other. But for now, just bother yourself with the boardable entities. Now we are moving to a one step higher, which is the undifferentiated thyroid cancers. Undifferentiated thyroid cancer, you have the poorly differentiated thyroid carcinoma and the anaplastic thyroid carcinoma. Letting you know, the difference between these two is what's the difference between poorly differentiated thyroid carcinoma and anaplastic thyroid carcinoma?
The presence of normal tissue?
Good, not normal tissue, almost there. The presence of a differentiated carcinoma. So who was talking to me? Sorry, I didn't see who was talking.
Alia, yeah.
Alia, yeah. So Alia, when you see a differentiated carcinoma in the field, like Alia, when you see a differentiated papillary thyroid cancer or a differentiated follicular carcinoma, and you see an adjacent area of solid architecture, trabecular architecture, nested architecture, there is no colloid in between the cells, and the cells look really aggressive with atypical mitosis and tumor necrosis because the cells are proliferating really fast. And if you even do Ki-67, you know what Ki-67 is, Alia? Since you didn't join the residency yet. Do you know what's Ki-67? Ki-67 is a proliferation marker. Okay, it's a proliferation index. It's an index of proliferation. Like if you throw Ki-67 and all the cells light up, this means that these cells are very actively proliferating. That's high Ki-67 index. And if you see like a little bit of cells lighting up here and there, that's low proliferation index. It's called Ki-67, let's say less than 1% or less than 2%. If you do Ki-67, you will see that in the undifferentiated or the poorly differentiated area, you will see a very, very high Ki-67 index, much higher than the differentiated carcinoma that you see in the same slide or in the same specimen. So the thing is, poorly differentiated thyroid carcinoma, you need to see a differentiated carcinoma in the field, which is either papillary or follicular. And also it behaves, it's some kind of a cancer which is not very aggressive as the anaplastic carcinoma and not very indolent as the differentiated carcinoma. It's somewhere in the middle, the poorly differentiated thyroid cancer. So you apply some criteria which called the Turin criteria. If you want to summarize this Turin criteria, I would say like follicular. It's usually follicular carcinoma in origin, by the way, not papillary. So follicular carcinoma of follicular cell origin without follicles. I'm not seeing any follicles anymore. I'm seeing just solid area, trabecular growth, insular growth, nested growth, but I don't see any microfollicles anymore. I don't see any colloid in the field. And with at least 1 out of 3, which is convoluted nuclei. Convoluted nuclei means the nuclei are very pleomorphic and very irregular, very ugly looking nuclei. And high mitosis, greater than or equal 3 mitosis per 10 high power fields, which correlate with the high Ki-67 index that I told you about. And you see a lot of tumor necrosis areas. See this tumor necrosis or coagulative necrosis here. It's like the necrosis that you see in the GBM, which means that the cells are very, very actively proliferating. See, you still see some leftover colloid here. Some leftover colloid, but the cells are nearly packing over each other. See this atypical mitosis? Yeah, I'm in trouble. So atypical mitosis, irregular architecture, solid, trabecular, insular, necrosis on top of follicular carcinoma, that's undifferentiated or poorly differentiated thyroid cancer. It usually arises by de-differentiation via de-differentiation of PTC or follicular carcinoma. It doesn't arise de novo. It doesn't arise as poorly differentiated from the beginning, but anaplastic does. That's very important distinction between these two entities. Okay, so the prognosis here is an intermediate prognosis between the prognosis of the follicular/papillary on one side and the anaplastic on the other side. It's in between. That's intermediate prognosis. Then anaplastic thyroid carcinoma, anaplastic means giant cells. I always say that. Giant cells in a thyroid gland is anaplastic. most of the time, the pictures in the boards show these giant tumor cells and a background of very, very, very malignant cells, haphazardly arranged, irregular pattern. So like disorganized cells, very malignant in the background, and giant cells in a thyroid mass. That's anaplastic thyroid carcinoma. Sometimes there is some rare variants like this one that you see here. It's called epithelioid variant. And sometimes you have sarcomatoid variant in which you have sarcoma, spindling. And sometimes squamoid, that's squamoid or epithelioid variant. However, the most common one which you get pictures in the boards is the classic one, which has spindle cells, a pleomorphic sarcoma like with giant cells. So sarcomatoid and giant cells are the most common in the boards. Anaplastic carcinoma, highly likely to metastasize locally. It's a very, very, very locally aggressive tumor. I always say it shows early infiltration of the trachea and of the esophagus, and it leads to stridor and hoarseness of voice. Stridor and hoarseness of voice and dysphagia. I can't say that right now, Noor, you know? Yeah. Abdurrahman, are you there?
I'm here.
Yeah, so Noor attended my step 1 and step 2. So Noor, I think Noor, you took step 1, step 2, and did you take step 3 with me? Yes, so step 1, step 2, step 3. So he got the 3 steps with me. So he remembered my words because my words kind of repeat itself. So I used to say this in Arabic when I the mood of the spread of anaplastic بيطلع من قفا العيان. So, so it go out of his nape. So that's what I always say in Arabic. So it's like
it's
just
so
to make
expressive, so.
just to make the students remember that it causes local spread. So it's very locally infiltrative. It shows a very rapidly growing, firm, fixed, highly infiltrative neck mass. Most common spread is local. And that's why anaplastic thyroid carcinoma is T4 by definition. Please remember this in your sign-outs, because your attending will ask you, what's the staging for this tumor? T4. We don't look for anything. We don't look for any capsular invasion, vascular invasion, lymph node. No, it's T4 by definition. That's it, done deal. The patient usually die within 1 year. It's very aggressive cancer with necrosis, mitosis, invasive growth that you see right there. So that's the anaplastic thyroid cancer. So now we know what's the difference between anaplastic thyroid cancer and poorly differentiated thyroid cancer. Okay? Anaplastic arises de novo. It's a separate entity by itself. But poorly differentiated thyroid cancer arises on top of follicular or on top of papillary thyroid cancer. Okay, that's a table for immunohistochemistry. I'm not a big fan of immunohistochemistry in thyroid, but you know, just remember that anaplastic thyroid carcinoma is always like negative in everything. Like you might end up having everything negative except for the P53. See, P53 and the P53 is positive in anaplastic and poorly differentiated thyroid cancer. And also we mentioned in the tall cell variant of papillary thyroid cancer, and these are the aggressive types. So P53 is always a marker of aggressiveness. Lastly, we have the medullary thyroid cancer. And as you see, I just skipped this squamous cell carcinoma. I won't even bother about it. So medullary thyroid cancer, that's a very important one. See, it's a 2-star diagnosis. It's full of questions, full of facts, in which you get some questions. So you need to remember that medullary thyroid cancer is associated with men type 2, 2A, and 2B. Both of them have medullary thyroid cancer, right? Yeah. I think men type 2, anybody remember which 2 tumors are common in men type 2? Medullary thyroid cancer and?
Parathyroid
Yes. Yes,
and
parathyroid. Yeah,
yeah, and Theo.
parathyroid and medullary. And then the third thing is the one that differ between men 2A and men. Yes.
It's not pheochromocytoma, right? Is it?
It's pheochromocytoma in men 2A, and in men 2B was mucosal neuromas,
Neuromas,
malformed
yeah.
habitus, this kind of thing. Oh, okay. So, but it's men type, in men type 2, whether it's 2A or 2B, that's medullary thyroid carcinoma positive. And in men type 2, we used to study this for our USMLE exam. It's associated with RET mutation. So please remember now. BRAF, PTC. RAS, follicular. RET, medullary. APC, cribriform morular. P53, anaplastic and poorly differentiated. So see, it's expanding. It's a big field for questions. So medullary thyroid carcinoma, men type 2, it's associated with RET mutation, shows frequent lymph node metastasis. However, it metastasized by both hematogenously and lymphatics, and it doesn't have a specific way of spread. So 2 criteria in order to diagnose medullary thyroid cancer. Anybody know the origin of this tumor? Well, the origin is right there. It's written here. It's coming from the parafollicular cells or the C cells. I showed you the C cells in the normal histology. The parafollicular cells or the C cells are actually coming from neural crest. Yes, that's a good one, Noor. It's good for the step 1 and step 2 CK exam, but not for the boards. Though parafollicular cells or C cells are coming actually from neural crest. The parafollicular cells or C cells, the medullary carcinoma, there are 2 criteria for microscopic diagnosis, which are neuroendocrine features. First thing, see neuroendocrine features. What's the classic neuroendocrine feature for any nuclei? What's in the nucleus here? It is what? Yes.
Stippling.
What Mohammed?
Nuclear stippling.
Nuclear
Salt and
stippling,
pepper.
which is salt and pepper. Yeah. Salt and pepper nuclei. That's the classic nuclear features of neuroendocrine or neuroendocrine features. So, but by the way, you might see some pseudo inclusions. So please don't run and jump in the pool of papillary thyroid cancer without looking carefully if you're seeing some amyloid in the background or any neuroendocrine features. And this is always there in the picture for the boards. You see this red desert or structureless red desert, which look waxy or light pink, light red, that's amyloid. And by the way, the amyloid here stains positive for Congo red. If you throw Congo red stain, you will see the apple green bifringens on polarized light microscopy here, because it's amyloid. So it shows amyloid. What kind of amyloid this is? What's this amyloid protein? Anybody know?
AL.
It's not it's not AL, not AA. That's actually calcitonin. Because the cells are secreting, the cells are secreting calcitonin. It's a lot too much calcitonin to the point that it forms structureless amyloid in the tumor itself. So it's calcitonin because this cancer or these tumor cells still secrete calcitonin, and it shows elevated serum calcitonin and positive calcitonin staining. See the IHC, positive calcitonin staining, that's the most specific. Aside, of course, from neuroendocrine markers, including synaptophysin, chromogranin, insulin, insulin 1, and these kind of things. So, neuroendocrine features, amyloid, and elevated calcitonin. Amyloid is very important. and it shows Congo red stain, apple green bifringence. It has a lot of variants and a lot of patterns. Like it might appear as the classic carcinoid tumor, organoid, this organoid architecture, or insular or nested architecture with the amyloid in between. However, you might see some kinds, sometimes you might see it in a sarcomatoid pattern. See these spindle cells? And it's a little bit tricky when it comes in a sarcomatoid pattern, but you still see the amyloid here in the background. And sometimes sarcomatoid areas are kind of areas in the tumor, but you see other areas in the tumor which look like the classic variant or the classic microscopic pattern. There's also this plasmacytoid cells. Sometimes these cells appear like plasma cells. It's called plasmacytoid, especially on cytology. You might get a question. I got this question in nearly 2 Q banks out of the in the 2 Q banks that I solved. Two out of 3, which is they give you a thyroid mass and they tell you this is the FNA from a thyroid mass, blah 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 blah, 30 years old female, blah blah, and then he's telling you that's how it looks like, and then you see a lot of dispersed cells, of course, like what you see in FNA, and you see plasma cells. It's like plasma cells. It's as if there is plasma. There's these like cells which look like oval, like an oval cell with an eccentric nucleus, and it's nearly like a clock face nucleus with this area of clearing around the nucleus. It's like plasma cells. And they always like try to confuse you whether this is a plasmacytoma or multiple myeloma or medullary thyroid cancer. However, when you see that in a fine needle, in a thyroid mass, in a patient suffering from a thyroid mass, that's medullary thyroid cancer. Don't call it anything else. In the boards, of course. In the real life, you might need to check the patient history and see if there's elevated calcitonin or blah, blah, blah. That's a different story. But here in the boards, it's medullary thyroid cancer. Let's just trust me. RET mutation, molecular, intermediate aggressive behavior, okay? The hyalinizing trabecular tumor. The hyalinizing trabecular tumor, I would just say this is the last thyroid cancer that we will go over. They don't know whether this is actually follicular in origin or papillary in origin. We don't know. But it's just so hyaline, so hyalinizing trabecular. It shows some kind of trabeculae of cells, as you see here. Nests of cells, large. The cells are large, polygonal, with some kind of occasional nuclear inclusions that you might see. However, the characteristic thing is you have hyaline basement membrane surrounding these cells. So see this hyalinized red basement membrane surrounding these trabecular of cells, like here. That's a trabecular of cells, and that's a hyaline membrane or hyaline basement membrane surrounding it. Well, can I diagnose this by H&E? I think no. But always in the 2 Q banks that ask questions about this tumor, 1 Q bank gave it as a diagnosis. It came as a diagnosis case, but they showed the tumor with this basement membrane-like material, and then another picture showing membranous Ki-67 staining. That's what makes this entity attractive for the boards and attractive for pathologists, is that it's one of the rare or the very, very rare tumors and the very rare cells in which Ki-67 stains the membrane, or MIB1, which is Ki-67 clone. It's a Ki-67 antibody clone. It stains membranous, not stain the nucleus. It's a membranous staining of Ki-67 or MIB1. So the QBank, which had it as a diagnosis, they know it's tough for me to diagnose it by H&E. So they gave me another clue They call it Ki67 or MIB1, and I saw membranous staining. I said, oh, okay, I see. So they are referring to the hyalinizing trabecular tumor. And the other QBank asked it as a plain text. There's no picture. They asked, which thyroid tumor show membranous staining by MIB1 or membranous staining by Ki67? That's the hyalinizing trabecular tumor. And that's why I highlighted only this information aside from the histopathology that you need to go over. Like these are trabeculae of cells with this hyaline basement membrane material surrounding, some kind of nuclear inclusions here or there. But the most important fact is the membranous staining by MIB1 or Ki67. Other than this, everything is rare and just read for fun. Like mucoepidermoid carcinoma, well, it's important, but it's important in salivary glands, not in thyroid, sorry. Sclerosing mucoepidermoid carcinoma with eosinophilia, oh, I'm sorry. Just give it up. Mucinous carcinoma, well, okay, abundant pools of mucin and floating cells, the same pattern of mucinous carcinoma elsewhere. Mucinous carcinoma of the colon, mucinous carcinoma of the thyroid, mucinous carcinoma or colloid carcinoma of the breast. It's everywhere the same pattern. Or colloid carcinoma of the lung and mucinous carcinoma of the lung, it's everywhere. Like pools of mucin with some cells floating, abundant pools of mucin with floating tumor clusters. Okay, I agree, but it's just like very rare as a thyroid primary. So even when you see it in the thyroid, you must clinically exclude a metastasis. It's rarely coming from the thyroid itself, might be coming from somewhere else. Ectopic thymoma, well, okay, read. Spindle epithelial tumor with thymus-like differentiation, read. The whole, this page is just read for fun. But the most important entities, no, we will not go over parathyroid today. The most important entities are the ones that we went over for the boards and even for practice and at the general pathologist level, okay? All right, so thumbs up for this tough session. That was tough. Okay, so now your favorite, the practice session. So let's practice. Okay. Let me start first. All right. So, Abdurrahman, the AB. The
I'm
AB.
here.
So let's start with the AB. So,
I get to change my name, I guess.
yeah, I think yes. I think after these lectures, you might plan for a change. But I have Adam, also one of my kids. His name is Adam, so it's AD. So it's,
Well, he gonna love you in the future.
he's nearly there. Yeah. So look at this.
Yeah,
That's
what about
yeah, that's a FNA from a
Mhm.
thyroid from a thyroid mass
Okay.
in a like 40-something-year-old blah 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 female. And I'm asking you, what is the most common mutation? Molecular mutation.
The most common gonna be RAS.
RAS. Anybody disagree?
Oh, is it wrong?
Is it wrong? What do you think?
Well, since you asked, it looks like it's wrong. I mean, I see Hurthle cells.
You see Hurthle cells. Does these look like Hurthle cells?
Oh, wait a minute. Is this plasmacytoid?
Yeah.
Oh, it's red then.
That's plasmacytoid. See these
Well,
cells with eccentric nuclei?
yeah. I didn't expect you're gonna start with the last entity, so
Yeah. So it's like a plasmacytoid. So that's
red.
it's red. Yeah, it's red oncogen. So that's medullary thyroid cancer. FNA from a medullary thyroid cancer. Please remember that medullary thyroid carcinoma, you might have plasmacytoid cells on FNA. I think this might be the amyloid, right?
I mean, I didn't see
I'm
one
not
at
sure, but
FNA, but yeah.
this thing I'm referring to this. You know, this might be the amyloid, but I don't know. I'm not sure. But that's plasmacytoid. Okay. So next in line is Alia. Okay. So let me get you something very straightforward because Alia is not there. She's almost there.
I'm here.
So can you remind me which program you are starting in?
Mount Sinai Medical Center in Miami Beach.
In Miami Beach. Okay,
Mhm.
that's a good place. A good even Miami Beach is a good place for living. Okay, so there. What do you think? What's your diagnosis? First, that's a thyroid mass. Okay, what's your diagnosis? And second question is, what's the most common molecular mutation?
Is it PTC?
It's a PTC, yeah.
Yeah,
So may
BRAF.
I ask why you said PTC or papillary thyroid cancer?
Papilla formation, like
Yeah, that's the
vascular core.
yes, that's the papillary pattern or papillary
Okay.
architecture. This make it a conventional type, right? So that's the conventional type, which is the classic type. It shows
Classic
these
type.
papillae.
Is that pseudocytoma bodies?
Yeah, well, we have
Calcification?
calcification here, so it's samoma bodies. Let's make
Mhm.
it more also towards papillary. And what else?
BRAF
Nuclear feature.
mutation.
No, the nuclear
Oh,
feature.
nuclear. Okay.
Yeah, I need you to like tell me like 2 out of the 6.
Okay. Grooving,
Grooving,
irregular contouring,
irregular contour, which is asymmetry.
overlapping,
Okay, good.
pseudo inclusions.
Oh, wow. Okay.
What else?
So we said enlargement, right? And asymmetry and
Yes.
inclusions, which are pseudo inclusions,
Mhm.
actually, and EAIO, yeah, O, which is what was the O? Oh my God,
Overlapping.
Overlapping, yeah, overlapping. I have mental block at the end of the day. I solved like today. I solved 80 questions, so I mean like
Oh.
So U is grooving, so nuclear
Groove.
grooving. It's like
Yeah.
U-shaped nuclear grooving. So EAIOU, and there is the samoma bodies, and there is a papillary architecture. So that's conventional papillary thyroid carcinoma. What's the most common molecular mutation?
BRAF.
BRAF. P with a P, right?
Yes.
Okay. All right. So next in line is Dina.
Yep, I'm ready.
Okay. All right. So, nope, nope. Yes. Okay. So the question here is, what is the associated syndrome? Let me share the screen. What's the associated syndrome with this thyroid mass that you see here? So it's a
I
thyroid
s-
mass.
So what I see here, it looks like a lot of sclerosis. Am I on the right track or?
Sclerosis. Is it sclerosis? Is it, so you mean that like you are talking about the sclerosing type of?
Yeah, but it doesn't have any other of the it kind of. So here's the thing, the cells look kind of spindly, I would say. Not spindly, but like,
Yeah, like that some nuclei look like cigar shaped.
yes.
Well, it's like a semi-sarcomatoid, but it's not really sarcomatoid. And then you have some structureless red
Is
area.
this the amyloid? The
Yeah, good job. So, okay. So
Okay.
amyloid sarcomatoid or semi-sarcomatoid pattern. And if you look carefully, actually, you will see that there is a stippling of the nucleus, and there is salt and pepper. Like, look at this, focus on this nucleus, this rounded nucleus.
Ah, yes.
Can you see this salt and pepper pattern? If you throw synaptochromo, you will see that this is synapto and chromo positive. So the diagnosis here is?
Medullary thyroid carcinoma.
Again, that's medullary thyroid carcinoma. So I'm trying to trick you. I'm repeating the same diagnosis 2 times. So, so what's the associated syndrome then?
The men type 2.
Men type 2. So men 2. Okay, good job. All right. Next in line is Hike.
Oh, yes, I'm here.
All right. So the next question coming is, what is the most common mode of spread for this tumor? Is it like lymphatic, blood? Okay, I will share the screen right now.
Ooh, that's an ugly one. I would say probably based on the size of the cells is the anaplastic one.
Yeah, that's the anaplastic thyroid carcinoma. So you see
I-
extra large cells, like a giant cell. So that is that one in the middle. That one in the middle. Oh wow, that's that one in the middle is very giant.
Yeah, the one on top of that and the one to the left, I think.
Yeah, these are giant cells. So that's
Mhm.
anaplastic. So then the most common way of spread is?
I think it was Venus, right? And
It was
Venus?
it was
Or it
not
was
Venus. The anaplastic was local spread.
local. Oh yes, yeah. Venus
Yeah.
was I think follicular probably.
Yeah, local spread. It's not venous spread. Yeah, it's local
Okay.
spread, and it was very aggressive tumor. Remember, it's
Yes.
it's very fatal within less than 1 year, and it shows P53 mutation.
Got it. Thank you.
Okay. Next is Mariam.
Yes, yeah.
Okay. So all right. So let's take this, and I would ask you maybe 2 questions, not only one. So put the high power on the side. Okay. Yes, side by side. So I'm sharing the screen. And there you go. You see a low power and a high power.
Yes.
So that's low power and that's high power. High power, you know why I'm giving you a high power. I'm giving you a high power so that you see if there is any papillary nuclear features or not. And that's a low power showing this thyroid tissue that proves that we are in the thyroid, and
Yeah.
this tumor.
Yeah, we
What do
have
you
a
think?
we
What do you
have a nodule well circumscribed, probably based on the picture in the left, and it's kind of hypercellular, and I can't see in high power. I can't see the feature of papillary.
You
So
cannot see. You mean you
yeah, I
cannot see?
can. Yeah, I can't.
Okay, okay, I see.
Yeah, yeah, and I think based on that, I will call this. And I don't, based on the picture in the left, I can't see any invasion. So I call this follicular adenoma.
Yes, perfect. I mean, as perfect as it can be. So that's follicular adenoma because we will see a well-circumscribed single mass here on low power, and on high power there is absent papillary nuclear features and some a follicle here, right? That's, I
Yes,
think,
yeah.
a follicle. There's no colloid though, but that's a follicle. So that's like a follicular pattern. Okay, so I need to look carefully at the capsule. Based on what I see here, that's the outer boundary of the capsule. The outer boundary of the capsule is very clean. There is no tumor reaching the outer boundary. You might see some islands, see? These are the islands of the tumor, which are there in the capsule, but it didn't fully penetrate through the capsule. So this is what we call what? This is what we call pseudo invasion, right?
Yes.
Pseudo invasion. That's not a true capsular invasion. And of course, you need to go high power and look carefully for any vascular invasion, but it's not showing up here in these pictures. So based on these images, we'll call this a follicular adenoma. Thank you, Mariam.
Thank you.
So, Mohammed.
Yes.
Yes, this one.
And there's still more.
Yeah, there's still more. There's always more.
You can give it back to Abdulrahman.
Oh yeah, let's just move.
Thank you. That's generous of you.
Okay, it's getting a little tough. So
I can see that.
yeah, what do you think
So
here? So look
I
carefully.
see.
Look carefully
I
in the two. You know what? Tell me your approach. Let's see your approach. Yeah.
So on low power, I see this kind of like nested between these like fibrous material or septae.
Mm-hmm.
And within each if you want to say like follicle, I wouldn't consider it like as a huge follicle maybe.
You're like compartment within each
Compartment, yeah,
Yeah.
compartments. I see a few mitotic figures. Maybe I'm wrong.
Could be. Yes.
Could be, and I see the nuclear pattern. It's a bit. I see like a little bit of nuclear grooving. They're overcrowded a bit.
Yes, that's
The
papillary nuclear
pattern,
feature.
yeah, papillary nuclear features, but I don't see as a papillary architect or pattern. Yeah. So this is more like, I don't know, could this be like an FP? Or it could be a follicular, well, maybe. I think it's like probably, no, I think it's an FP because it has PTC features, but they're more like in a follicular pattern, I think.
Doesn't it look isn't there any like anyone else want to throw anything else? Poorly, Noor, yeah. Since I don't have any more pictures, so Noor, can you like tell me your input here? Because that's a tough case actually. This is a tough case. So Noor is giving me an input here. He's saying poorly differentiated. What else? Do you have
I second that.
Well, okay, so you're seconding Noor. But so let's talk about NIFTP, but because you're saying that there is papillary nuclear features here, so you are sure that there is papillary nuclear features. So let's make it papillary thyroid
I have to
cancer.
go high power, of course, but like low
But
power,
this is yeah. This I will second your thing. I will tell you that this shows papillary nuclear features. It is. It shows crowding, like overlapping, and there
yeah,
is clearing, like orphan
Mhm.
Annie in some nuclei. So that's
yes.
papillary. Papillary. Anybody have anything to throw? Yes, Mariam. Mariam.
Is it maybe cribiform? One
Good
more.
job. Excellent. Well, I think Mariam is someone who focuses on details. So I don't know. Do you have any preferred specialty in mind, Mariam? Any preferred specialty?
Yes, heme.
Heme. Oh, okay. That's why I would tell you you will go for heme or you go for cytology. These are people who focus on details and see like the lot of details. They enjoy looking at cells individually. They hate like the pattern and just the broad picture. This Muhammad, do you see it now?
Yeah, I do see it, and I'm kind of like it occurred to me as cribiform, but I didn't say it. I don't know why.
Yeah, see
Like
these
I'm upset a bit.
yeah, cribriform. So cribriform morular. So that's morules of cells, like what you said. It's nests or masses of cells, morules of cells with some kind of cribriforms in the middle with papillary nuclear features. That's cribriform morular pattern of papillary thyroid cancer, which is associated with which mutation?
Hmm,
FAP.
Colon.
FAP.
Yeah, the
Ah.
FAP. You remember cribriform colon. Cribriform.
Yeah, I missed
yeah,
the
that's
beginning of the lecture.
FAP.
Sorry.
Yeah, you missed the beginning. Oh, that's why. Okay, so you have the. It came in the RISE actually. In this year RISE, I think there was a question asking about which type of thyroid cancer associated with FAP, and it had this choices is cribriform morular type. So that's the cribriform morular pattern. All right, so that's it for today. Anybody have any questions?
Why the last picture is not undifferentiated?
Poorly differentiated type. Well, yeah. I mean, you can of course debate on that, but I mean, this is why we need to look at all the areas of the picture. Or all the areas of the slide. Like if we have a slide, we look all around. But that's a cribriform morular pattern, which have the because poorly differentiated, you will have some kind of convoluted nuclei, atypical mitosis. Did you see any of these in the picture?
No.
So definitely they will give you something as a clue. Like they will give you like a picture showing an atypical mitosis in the field, or it shows like a kind of convoluted, very malignant looking nuclei, which is the undifferentiated type. But this one, it shows just the papillary nuclear features, but just the cells are forming masses or morules with some like areas of cribriforming. That's cribriform morular. I know it takes a lot of experience and it's tough though, but that's why I said it's a tough case. It's not an easy one, but you need to make sure that you get exposed to everything. Any question, Mariam? I see that you are unmuting or.
No, I just wanted to add that if we see the features of PTC, poorly differentiated will be ruled out because one of the criteria is absence of
Follicular. Yeah. Let's yeah. That's another thing. Yeah, I missed that. Yeah, it's just we're seeing here papillary nuclear feature, and you remember in the poorly differentiated or undifferentiated, it's usually coming on top of follicular. But in rare situations, it might also come on top of papillary, but it's usually follicular. It's usually follicles with and without. You remember Turin's criteria. Okay, so that's it for today. Today is Wednesday. So yeah, so I'll see you Friday. So after tomorrow, I will see you Friday. So on Friday, we will go over, I think the next in line is salivary glands, if I'm mistaken, right? Is the big boss the salivary glands? Yes, next is salivary glands. Next in salivary glands, and then we'll go over other selected head and neck topics, which will include parathyroid and the other stuff. Okay, so that's it for today, and see you on Friday. Thank you.
Thank
Bye.
you, Tah.
Bye.
Thank you.
Thank you.
Thank you.